So happy to be here with you all. This is going to be a little bit like the nose cone camera view on a drone strike. We've been flying high with Dr. Kelly and getting a high altitude view of new value and healthcare delivery from Dr. Martin. We're now going to plunge back into the clinic environment, and I'm going to try to give you an idea of just what the scope of practice in a modern head and neck clinic environment is, and just how much diagnostic and therapeutic intervention that we're capable of in an outpatient environment. You may see this as what your mom or dad would regard as an ENT physician. Those days have long ago changed. We try to maintain some high-touch care in our department and really be compassionate and careful with patients. But otolaryngology and head and neck surgery long ago has evolved into a very sophisticated and increasingly specialized system of care. And part of that is driven by the complexity of the anatomy and the proximity of all of the structures that involve special sense, proximity to the brain, the eye, cranial nerve distributions, as Dr. Griffith alluded to before. But then we've got all of these upper aerodigestive structures in very, very complex vascularity and neurological systems. So currently, in the head and neck surgical office, there's a vast array of technology and capabilities. Otomicroscopy allows us to do some microscopic interventions and careful diagnosis of people's ear problems. We have high-definition video endoscopy. That's applicable in the sinonasal tract for laryngeal applications and also diagnosis of pharyngeal and esophageal pathologies. Sinus CT imaging is a standard part of our office practice, and it allows us to immediately review pathology in the sinonasal tract with patients, create a plan, and very often allow them to see exactly what the justification for various surgical interventions are. Audiological assessment, Rebecca Lewis referred to a lot of the sophisticated audiological testing that is currently done not just in a cochlear implant program, but every day in a head and neck office, which includes not just audiology, but tympanometry and various other measures of cochlear function that are very useful. Speech and swallowing assessment has been integrated with ENT and head and neck surgery for a long time. That currently is going to become a very integral part of our practice with our own speech and swallowing pathologists. And then many of the diagnostic procedures that required tissue acquisition, those things used to require open biopsies, but many of them now are amenable to either unguided or guided needle biopsies in our clinic. Therapeutically, we are constantly taking skin lesions off and reconstructing those things that are appropriate in a local anesthetic or mildly sedated environment. Soft tissue infections and upper aerodigestive pathologies can be drained often without going to the hospital, as Dr. Griffiths had demonstrated previously with peritonsillar abscess. External ear canal lesions, repairs of the eardrum injections for sudden hearing loss and Meniere's disease, as Dr. Volker had referred to. Those things can be done in our offices. And then many of the endoscopic treatments that are applicable for vocal cord disorders, such as augmentation injections for vocal cord paralysis and for vocal fold bowing and weakening of the voice with age, those things can all be done. Thyroid cysts and other cervical masses sometimes can be treated in our offices. Many of the things which vex patients the most, such as hearing loss, can be cured. Earwax is probably the most gratifying problem that a patient can have when they walk into the office, because they walk out able to hear again, and that can be done painlessly either with or without the microscope. As you all know, things like middle ear effusions are very common. That's another cause of conductive hearing loss. Those things can be drained in the office with or without application of a ventilating tube. And then we have some things on the horizon which will probably stun and amaze all of us. Well, cochlear implantation is, I believe, a miraculous thing. There will be, in the near future, the ability to regenerate nerve cells within the cochlea, and those will likely be office-based treatments that can help people to actually regrow some of their neurological function. Simple things like repairing eardrum perforations, those were always relegated to the operating room, but in the office, smaller perforations can be treated under local anesthesia by placing fat grafts in the eardrum and achieve sealing off of the hole as demonstrated here. I'm going to spend the majority of what I talk about here on nasal dysfunction and nasal obstruction. One, it's kind of a favorite topic of mine, but also nasal anatomy is quite complex, and it's not that familiar to many people in the room. The nose is a complicated interface for special sense, for respiratory health, immunological response, and is affected by infectious diseases. And it also is a primary structure for facial form. Besides being a conduit for airflow, as been discussed before, humidification, filtration, and vocal resonance are all determined within the nasal tract. Olfaction, as Dr. Anwar was discussing earlier, is linked to our primitive rhinencephalon, and as such, it has very strong connections to and implications for not just being able to perceive roses versus the cat next door, but it is involved in memory, emotion, identification of kin, food safety, pheromone detection, and sexual arousal. COVID, if anything, has brought to the fore the appreciation of just how important that olfaction is. The allergic response, as many of us in the room, whether we're primary care physicians, otolaryngologists, or allergists, we understand just how involved that the nose is with the allergic response. And besides histamine release, sneezing, mucociliary clearance, all of those things are fundamental processes occurring there. In the back of the nose, there's a deposit of nasopharyngeal lymphoid tissue, which is a first-line response to infectious agents, and it's also a reservoir for trapping those infectious agents there, whether they're viral, bacterial, or fungal. COVID, again, is an object lesson for us all in that. But the most important function of the nose is to be able to support devices such as this, which give us our identity and our sense of humor. Essential nasal anatomy crosses a wide spectrum of morphology. So we have to appreciate that, understand that the nose doesn't just reside by itself, but is a fundamental part of the rest of facial anatomy. I'm going to run through quickly some of the nasal anatomy, internal and external, that will explain some of the other office interventions that we do. So the nasal exterior is both bony in the upper part of the nose, and then there are complex cartilaginous structures that form the projection and support for the lower nose. There are a number of different muscles that attach to the nose, which both dilate and also compress the nostrils, so they in effect do control some airflow. And they're also involved in emotional and expressive movements of the face. The nasal interior, looking at the midline, is cartilaginous in the front. This is the central wall of the nose. Then bony in the upper and the back portion of the nose. You can see that the brain rests on a thin separator between the cranial cavity and the inside of the nose. The lateral wall of the nose does have olfactory mucosa in the upper and lateral aspect. And then the turbinates, which, as you know, are part of regulation of respiratory resistance and airflow, and also produce secretions and mucosal clearance. So the nasal interior was discussed before as demonstrated on CAT scan, and this will show very well how the interior of the nose is relatively complex. There are a number of channels that need to stay open for the sinuses to drain properly, and the relationship between the septum and turbinates is fundamental to airflow. There's an unfortunate complexity of neural innervation of the inside of the nose. Part of this is sensory. Some of it is secretory and determines how much secretion is produced and what the consistency and viscosity of that secretion is. How the nasal function is determined has both circadian variation as well as postural changes that are effective. If anyone is with a tendency to nasal congestion has laid down at night with your head turned to one side, you realize that that side that's dependent quickly will get congested. If you happen to have a septal obstruction and turbinate enlargement on the other side of your nose, pretty soon you're not breathing at all. Dr. Kochar demonstrated the anatomical limits of the external and internal nasal valves, which are very important for perception of nasal airway patency. One thing that should be noted, it's scary to go back to high school physics, but the Venturi effect is a known physical property where if you are trying to force air through a narrow tube at a high rate of speed, that there's a vacuum effect on the inside of that tube. This is exactly what happens to the inside of the nose when someone is trying to forcefully inhale when they've got restricted airflow and weakened sidewalls in the region of the external or internal nasal valve. One thing that was discussed before and which deserves some reiteration is that nasal endoscopy is a very fundamental part of what allows us to accurately diagnose what's going on in the inside of the nose, to monitor people's responses to treatment, and also to guide therapeutic interventions. So nasal hemorrhage, for instance, that used to be something that was routinely treated by packing the nose, which is a hellacious experience if you've ever had it done. But now with nasal endoscopy, we very often are able, just under local anesthesia, to topically treat nasal bleeding or to use electrocautery to do specific focused sealing off of blood vessels so that the patient walks out of the office without a nasal pack in and pretty much able to go back to their regular life. Nasal polyps and other lesions can be endoscopically excised in the office. And then balloon sinuplasty was alluded to as it's a corollary of the balloon eustachian tube dilatation. Balloon sinuplasty is an effective thing for people that get not really chronic sinusitis, but people that are prone to having recurring episodes of acute sinusitis. So if their anatomy is narrow and then they are stimulated with either allergic, infectious, or other environmental challenges, they may just over and over again develop sinusitis, which is a big problem. So rather than going in and having to do a big sinus operation that endoscopically creates large windows or openings into the nasal interior, a balloon can be inserted that then is able to dilate a stenotic channel that leads into one of the sinuses so that it functions better. So in the upper left, you can see obstruction of the left frontal and ethmoid remnant. The obstructed left frontal duct is demonstrated in the upper right. And then after insertion of the balloon over a catheter, just like with the eustachian tube balloon dilatation, the functional opening of the frontal sinus is much larger, and this helps to resolve those acute and recurrent infections. Vasomotor dysfunction is something that many primary care physicians will encounter in their practice. As patients get older, the neural control for the production and the distribution of secretions in the nose changes. Just like hearing nerve cells and eye nerve cells deteriorate with age, the same thing happens in the inside of the nose. And so the Vidian nerve, which comes in from the skull base in the back of the nose and then gives off a posterior nasal nerve going to the turbinates, that often becomes dysfunctional with age, and patients will bitterly complain that their nose runs right after they get up in the morning, it'll run when they get out of the shower, it runs when they think about eating food, and it's embarrassing and vexing for them. There are some nasal sprays that can be helpful for that, but they don't always work. So one thing that can be considered is a non-invasive treatment that can be done in the office. There's two basic varieties of this. One uses cryotherapy. In the upper diagram there, you see a catheter attached to a balloon that's placed into the back of the nose under the posterior aspect of the middle turbinate. And basically, nitrogen gas is injected into that balloon, which freezes, and it will cause a cryoablation of the nerve entering the back of the nose. There's another alternative which uses radio frequency energy that's delivered through a probe. So this is basically microwave energy that is being applied to create controlled heating of nasal nerves that enter the back of the nose as well. Some of these non-invasive technologies can be used in our offices to impact the patency of the nasal airway as well. If you look at the lower diagram there, the septum would be towards the left aspect of that schematic, and then the nasal valve where the upper lateral cartilage impresses on the nasal airway from the side, and also the inferior turbinate that's shown to be swollen there. That restricts the nasal airway. There is a way of non-invasively treating, again, with this temperature-controlled application of radiofrequency energy to create a more open airway, as you would see in the upper diagram. Coblation is another form of radiofrequency energy that we use in the office environment. It's done under local anesthesia. So you've got a probe which basically delivers microwave energy, creates heating inside the soft tissue part of the turbinate, and then that's done for a specified period of time in a number of locations, and that will cause the turbinate to shrink and open the airway up. One aside, just like when Dr. Anwar was talking about the patulous eustachian tube as being something that could produce kind of a paradoxical sense of ear fullness, just like a closed eustachian tube would, there is such a thing as what's called the empty nose syndrome. This CAT scan demonstrates a person who has had overly enthusiastic nasal surgery. And when you look there, the septum is midline for sure, but you don't see any turbinates projecting into that airway. So that person, even without a speculum, you'd be able to see their nasopharynx looking through their nostril. And this is a patient that would bitterly complain about having a stuffy nose or one which is excessively dry, maybe prone to crusting and colonization with staph. So it's a situation that really we want to avoid at all costs. We do have effective treatments in the clinic for snoring and sleep apnea. Even if the tonsils are not especially large, if the person has hypertrophic uvula, if they have a dependent soft palate that's floppy and lax, there are treatments that have been developed, such as pillar implants, which are fabric stems that are injected with a specialized needle into the palate that, just like struts in an airplane wing, can produce some stiffening of that palate and have been demonstrated in some studies to show effectiveness for certain degrees of snoring and sleep apnea. And then the Alevo implants, which are a little bit different. They have barbed projections so that when the implant is injected submucosally or into the muscular aspect of the palate, that the implant can be drawn back and it will engage the soft palate tissues and actually hold it in a more up and forward position. Laryngeal diagnosis and treatment, that's something that Dr. Metazadeh will talk about in much more detail, so I'm going to leave that for him. Video stroboscopy, let's see if I can activate this. This will show, maybe. You can see a wave-like vibration of the vocal cords that's acting at a high rate of vibration. When that's normal, then the patient has excellent vocal quality, and it also demonstrates good apposition of the vocal cords. And I'm sure, will discuss other interventions that can really be useful. This really shows here an example of someone with vocal cord paralysis in the left upper. When the cords are brought together, you can see that gap between the two vocal cords, and or vocal folds is the actual term. And then in the lower right, after there's been injection of material that medializes the cord, you can see the effect of bringing the vocal cords together in much better apposition in the lower left. Botulinum toxin, great on steaks and cleans nylons too. There are an incredible number of uses for botulinum toxin. It's been used, as Dr. Kochar referred to, in facial paralysis and synkinesis. For people with overactive salivary glands and for ones who have salivary cysts or fistulae, we can use botulinum toxin injections to decrease the unwanted flow of saliva, which is both choking and also socially embarrassing. TMJ syndrome, we all see plenty of patients that have TMJ problems, whether it's giving them headaches, trismus, or problems with their dental occlusion even. These people often will not get that much better with anti-inflammatories and even with dental splints. But we use botulinum toxin that's injected selectively into masticatory muscles. That can provide great relief to these patients and keep them from wearing all their teeth away. As you all know, hyperhidrosis of the scalp, palms, axillae is a social problem that can be treated with botulinum toxin, as can many of the effects of facial aging. Vocal dystonia will be talked about by Dr. Medizadeh for sure. Interestingly, scar management can be affected by Botox injections or botulinum toxin injections as well. There's a certain amount of stress across a scar that will determine whether it heals as a fine line or whether it becomes hypertrophic, raised, or depressed. And when Botox is injected into the vicinity of a scar repair or revision, it often will make the resulting scar a much better quality and much less conspicuous. Parenthetically, when I've injected botulinum toxin for various other things into patients' foreheads, I've seen many times that acne breakouts that have been vexing to them at any age will stop or become markedly improved because it's a eccrine secretory problem of the skin. So as far as the office environment and the sophistication of the clinic, really we barely scratched the surface. There are many other things that we'll be able to do in the upcoming years, and look forward to sharing those with you.